Welcome to our joint preparation class talking about hip replacement surgery. My name is Dr. Cerna. I'm one of the orthopedic trauma and reconstruction specialists here, and I do adult hip and knee replacements. This is an overview of our orthopedic center team, and we show this because you might meet more than one provider during your hospital stay, and we work as a team to help provide the best care possible. Goals for you and your family attending this class are to recognize that hip replacement is a reliable operation to relieve pain and restore function, to describe what to expect of the replacement procedure and the process, and to discuss the risks of the surgery itself. The goals of your hip replacement are to improve your quality of life, and we hope to do that by relieving your pain and restoring your function or movement. We also hope to increase your activity, restore any leg length that you might have lost, and to hopefully eliminate any limping. Here is an x-ray showing both hips. On the right-hand side is a relatively normal hip. There is some arthritis here, but compared to the left side, there's a more normal joint space here, and this is where the cartilage lives between the two bones. There's not much in the way of bone spurs. There's no cysts or holes in the bone. But if you come over to the right side now, you see big bone spurs. The joint space here in the center is almost completely gone. This is what we call bone-on-bone disease. It looks like there's little pockets or holes in this bone here, and that all points to severe arthritis. As the hip cartilage wears, bone spurs form, and the hip becomes stiff. What we do is we replace the worn bony surfaces with a new ball, a new socket, and a new cushion in between the two. And we also have this stem that goes down the femur or the thigh bone, and we hope to restore leg length and stability to your hip in the process. We use ceramic and plastic most commonly. Other implant materials may be used dependent on your situation. In general, the socket is metal and is impacted into the pelvis, and bone will grow into the back of the socket. The screws that we use are to secure the socket at the time of surgery. A metal stem goes down the femur or the thigh bone, and this may be cemented into place or press fit, which means it's a really tight fit between the metal and the canal of the bone. The socket and the stem are made of titanium. A plastic or ceramic liner goes into the socket. A metal or ceramic ball will go on to the stem. If the ball is metal, it's made of a hard cobalt chrome alloy. Most hip replacements use a metal ball against a plastic cushion. We may recommend alternative bearing surfaces or combinations of materials, again depending on your situation. Some of the older ceramic bearings you may have heard can fracture or break and may squeak. The newer generation ceramics eliminate these possibilities. Not completely, but they are a lot better than the older generation. This is a picture of a cemented stem here. And if you notice, it's a little bit thinner and a little bit smaller than the press fit stem, and there's this white mantle of cement that goes around the stem. This is a ball with a plastic liner, and we use cemented stems in patients with softer or poorer bone quality. So if you have osteopenia or osteoporosis, brittle bone disease, we may recommend using a cemented stem. The surgical approach is how we get into the hip. There's different ways of doing so. We can go in posterior, which is through the back, anterior, which is through the front, or lateral through the side. Each approach has advantages and disadvantages. Neither of these or any of these has been shown to be advantageous or superior to any of the others, and we can usually recommend the best approach for you. The surgical incision is made either on the side of the hip or on the front of the hip. We generally make the incision long enough to see the area around the hip and what we're going to be working with. We try to use techniques to spare muscle, and as surgical techniques continue to improve and technology advances, we can usually do this through smaller and smaller incisions. On the day of surgery, you'll meet your surgeon in the surgical prep and recovery area, and we'll initial your hip and answer any final questions you may have. Family can wait with you while you're in that area, and then you'll go to the operating room first, and then to our post-anesthesia care unit, or PACU, which is our recovery room. The surgery itself generally will last 2 to 3 hours, recovery will last 1 to 2 hours, and finally you'll go up to the medical surgical unit on the 4th floor of the new hospital tower. Pain control is something that we discuss really early and throughout the process. Our goal is to control your pain after surgery to allow you to begin moving around and participating in therapy. We ask that you expect some discomfort and some soreness. This should gradually improve as time passes. There is a difference between no pain and controlled pain. We do use a multimodal regimen or approach to your pain control, which means we give combinations of different medicines to optimize your pain relief. We use analgesic medicines like Tylenol, anti-inflammatories, which are your Toradols, your ibuprofens, your Motrins, your Aleve, neuropathic medicines like Neurontin and Lyrica, muscle relaxants like your Valium and your Flexeril, and narcotics, of course, like your oxycodones and your morphines. Doses are generally started preoperatively while you're waiting to have your surgery, and they'll continue throughout your hospital stay. Intraoperative treatments such as joint capsular injections are also sometimes performed. IV medications, which used to be the norm, are now the exception rather than the rule, and we try to limit your use of narcotics because we know that these can have downsides and side effects that are not necessarily all that helpful. Positional changes, breathing and relaxation techniques, massage techniques, they're all part of our multimodal approach. After surgery, physical and occupational therapy are important for a good outcome. Therapy will generally start the day after your surgery. They'll help get you out of bed, walk with a walker or another assist device, and weight bearing is tolerated as allowed in the vast majority of patients after this type of a surgery. We do talk about hip precautions in that these are certain positions that we like for you to avoid for about the first 6 weeks after your surgery. And this is because this is when the tissues around your hip are healing, and we don't want to put undue stress on those tissues. We ask that you don't flex your hip to greater than 90 degrees. We ask that you sleep with a pillow between your knees. No crossing of your legs, either sitting or in bed. No internal rotation of the hip, which means bringing your knee in. And we like to we don't want you to put your toes towards your nose. You must use a walker or other device until your strength returns in order to avoid falls and to maintain your stability. We like you to have your toes pointed out in bed, and again, no crossing of your legs in bed. In addition, if you have your hip done through an anterior or front approach, we ask that you avoid external rotation of the hip, which is extremely taking your toes out to the side, and avoid extension of your hip, which is bringing your foot behind you. All of this will be covered by your physical therapist and by your care team. While you're in the hospital, additional doctors will help take care of your non-orthopedic issues, such as any high blood pressure, diabetes, heart or lung conditions that you might have. We now use a hospitalist medicine service who will see you after your surgery and co-manage these issues with us. If you are not getting a medication that you think you should, please ask. Similarly, if you're getting a medication and you're not sure why, please ask. It is not uncommon for some of your routine or home medications to either be changed or stopped around the time of such surgery.
I grew up in Eau Claire, Wisconsin. I hail from a family of physicians. My father, in fact, retired from Mayo Clinic Health System after 34 years. As a young child growing up, I could sense that my father was doing important things to help people, and I could tell that he enjoyed his work, and that inspired me to follow in his path. As I approached the end of my training, I had to decide what field of medicine would suit me best. I eventually chose hospital medicine. A hospitalist is a physician who specializes in the treatment of hospitalized patients. While an outpatient general physician treats a variety of conditions in the clinic setting, hospitalists care for patients whose condition requires hospitalization. We take the place of your outpatient physician during that time period. Following discharge, you will return to your outpatient physician. That doctor has full access to all details regarding your hospital stay. The hospitalist team provides daily, round-the-clock medical care for the patient until the time of discharge. The term hospitalist was first coined in the mid-1990s in response to a growing trend in modern medical care. Since that time, hospitalist programs across the country have increased rapidly. The reason for the specialization in hospital-based medicine is simply better patient care. Unlike an outpatient physician who has obligations in the clinic, the hospitalist is present at the hospital throughout the day, making it easier to respond to test results quickly and accommodate the patient's changing needs. Multiple studies over the years have indicated that patients under the care of hospitalists have better outcomes and shorter stays, which in turn leads to lower costs. At Mayo Clinic Health System in Eau Claire, we founded a hospitalist program in 2003. Since then, the scope of the practice has expanded considerably, and we have added hospitalist programs at Barron, Bloomer, and Osseo. Our hospitalist team cares for a variety of patients and conditions including diabetes, hypertension, heart disease, emphysema, strokes, kidney disease and infections. We also commonly consult on surgical patients to provide a medical opinion on multiple issues. Patients are assigned to a specific hospitalist during their stay. Due to the nature of our shifts, however, the doctor who admits you may not be the same doctor who discharges you home. Communication is key in our program. We need to be able to communicate effectively between ourselves, consulting physicians, nurses, therapists, and the patient's family doctor. Most importantly, we need to communicate well with you and your family. This helps to ensure excellent patient care at every level. We know that medical information can be very technical and complicated. Therefore, we encourage patients and their families to ask questions of the hospitalist so that they understand both their illness as well as their treatment. It is essential to remember that we work for you, and your needs come first. We want you to understand your condition so that you can collaborate with us to help make the best decisions for your medical care.
So now we'll talk about some of the risks around this surgery. You are at risk for a blood clot after hip surgery or injury. Calf squeezers, we call them sequential compression devices, or SCDs, are used when you are in the hospital and should be worn whenever you are in bed or sitting in a chair about 18 hours a day. Anticoagulation medication is given during your hospital stay. Those are blood thinners. And aspirin generally after discharge. If you are already on an anticoagulation or a blood thinner, please talk with your surgeon and your primary care physician about what changes might need to be made for your routine medicine and dosing. Generally, the risk is 30% or more if we don't treat for blood clots. Treat to prevent blood clots. Clots can go to the lungs and can be fatal. Your risk is reduced to less than 1% or so if treated with medication and squeezers, and getting out of bed and walking helps to prevent blood clots better than anything else. You will get antibiotics around the time of your surgery and for 24 hours after your surgery. Surgeons, assistants, and scrub techs wear spacesuits in the operating room, and using all precautions, in general, the risk of infection is about 1%. Infection may occur months or years after your surgery and may mean removal of your implants and almost certainly more surgery. Here's a picture of Dr. Brand on the left-hand side with the patient on the table. Everything that's touching blue is sterile. Those are the spacesuits that we wear, and the anesthesiologist is sitting behind the blue curtain in the background. Blood loss is a risk during and after surgery. Bony surfaces will bleed during surgery, and there may be some continuation of this bleeding after surgery. We'll check your blood count each morning after surgery, and if you have symptoms from a low blood count, you may need to have a blood transfusion. We routinely give a medication called tranexamic acid, abbreviated TXA, which has been shown to decrease transfusion rates or the need for a transfusion. Dislocation. This is an artificial joint and it may slip out of joint. If it does dislocate, this often requires a trip back to the hospital to have the hip put back in place. You may be required to wear a brace if it dislocates, and multiple dislocations may require revision surgery to fix the problem. Arthritic hips lead to loss of leg length. As that joint collapses, your leg might feel like it's getting shorter. We aim to restore your leg length, and we may even intentionally lengthen the leg to prevent the hip from dislocating. The longer we make it, generally the more stable it is. The leg may seem long after surgery and may require the use of a shoe lift on the opposite foot, which may be temporary or occasionally permanent. In general, we try to make your legs the same length, or if we do anticipate performing the same surgery on your other side, we may lengthen the first side and then match it with the second. We encourage patients to wait as long as possible before pursuing a hip replacement. Implants do wear with time. The wear rate in general is about 1% a year. Revision surgery may involve changing the plastic or changing one or all of the metal parts, and it is certainly more challenging with a more difficult recovery. Surgery is a stress to your body. Medical complications such as heart and lung problems, stroke, stomach problems, constipation, all can occur. A physical with your regular doctor and an EKG are required before surgery, but despite all of these precautions and evaluations, unforeseen medical complications can still occur. And again, please discuss your other medical issues and your medications with your primary care doctor because changes may be required. You'll meet the anesthesia provider on the day of surgery. They'll discuss your anesthetic options, such as whether to pursue or proceed with a general anesthetic, spinal, epidural, or even nerve blocks. Nausea and vomiting are still the most common complications or side effects, but more serious side effects can occur. please tell the anesthesia provider of any past experiences that you've had with anesthesia or anybody in your family. In general, the recovery time is 6 weeks before your walking returns to near normal. 3 to 4 months until you're back to a normal level of activity, 6 months until you feel like you're reaching a normal endurance, and 12 months for maximal recovery. We focus on exercises for movement or range of motion first and then strength and endurance. And getting back to work is very individual, so please check with your surgeon. In summary, hip replacement surgery is a reliable operation to relieve pain and restore function. As with any operation, there are associated risks. All of the precautions that we take are to minimize risk and to provide for a routine operation. And the purpose of today's talk was to provide you with information about hip replacement surgery. If you have any other questions or concerns, please address these with your provider, your surgeon, or your care team. Thank you.
Hi, my name is Tracy Samuelson. I'm one of the triage nurses that works here at Orthopedics at Mayo Clinic Health System here in Eau Claire. I'm going to be talking to you about what we do to get everybody ready for the joint prep class for hips and try and make the day a little bit easier when you come in for surgery. Our goals are going to be discuss the steps to take you to get you ready for your surgical procedure, discuss what to expect for the surgical experience, and identify what you need to achieve the best outcome, and recognize why it's important for you to participate in your plan of care. We're going to help you plan ahead. We really want you to plan ahead to return home, identify who will take care of you after you have surgery, and plan for about 2 weeks after you have surgery, whether or not you're going somewhere for rehab or just straight home. We want you to simplify your meals, plan for 2 weeks of easy or no preparation meals, and any planned dental work. That should be done at least 1 month before you have surgery. Planning ahead, any of your regular doctor appointments for pre-surgery, we want you to have your blood work, your EKG, physical exams, and to discuss your medications. There's certain medications that you need to take and not take before you have surgery, and we definitely want to go through all those with your primary doctor. You also have an appointment with your surgeon, and we'll be discussing your final preparation for your surgery and when your surgery is and any kind of updates. If you do smoke, we'd like you to quit smoking because smoking does delay the healing process, so we want to talk to your regular doctor about getting you some help. We want you also to talk with your surgeon about if you have a fever, cold, infection, or rash before your surgery date. Those things can delay your surgery. What to bring to the hospital: loose, comfortable clothing, your personal items that you would need, medication list, a CPAP or BiPAP machine or mask. That is because the ones that you have at home do fit a lot better. Your joint prep replacement information folder, and just realize that Mayo Clinic Health System is not responsible for lost or broken items. What not to bring to the hospital: large amounts of jewelry or valuables, credit cards, money. You do not need to bring your medications. We have them all here. Mayo Clinic Health System is not responsible for those lost or stolen items. The day before your surgery, the surgical prep and recovery nurse will call you, and they'll review all your medications, what you should take the night before surgery and the day of surgery. They're going to tell you when to eat, when to stop drinking water or any other fluids, and when to smoke and not smoke, any of those restrictions. Your hygiene instructions, when to wash up the night before or the morning of surgery. And remind you to call the day before and get the time that you're going to come to your surgery. If you're going to be coming the day before, if you're coming on a Monday morning, we're going to have you call on Friday afternoon and find out the time that you would come in for that. If you're coming in for surgery on Tuesday, you would call Monday at 4 o'clock and find out the time of that surgery. The day of surgery, we'd have you take those medications that the surgical nurse had talked to you about, and then you would check in at the Mayo Clinic Health System reception desk. If you park in the parking ramp, you just walk down the long hallway, and it'll be this area right here by the registration. The day of surgery, you'll be taken to the surgical prep and recovery room, and you'll be asked your name and your date of birth many times by everyone who is in contact with you. This is done for your safety. Family and friends are welcome to come along, but do try to limit to that about 2 people on the day of surgery because the rooms are very small as you get started. Surgical prep and recovery, the nursing administration, they'll get you going and ask you many questions and help you get ready for surgery. They're going to put those leg squeezers on. They're called SCDs. And they'll also have the anesthesiologist come in and talk with you and ask you whether or not you're going to have a general or spinal. This is also a time to talk to your surgeon, and he will initial on your leg which side that you're having surgery on. These are the leg squeezers, or SCDs. You'll have those on while you're in the hospital, during surgery, and then after, and pretty much when you're not up walking around. And they'll take you to the operating room, and then that's when your family will go to the waiting room, and they'll get a little card that tells you where you're going to be, so they'll be able to keep in touch with you, and they'll have a paging system. The operating room, you can see in this picture, they've got the monitors, antibiotics are hanging, surgical scrub team is there. The OR staff will communicate with your family throughout the surgery if there's any issues that they need to discuss with them. Then after surgery, you'll go to post-recovery room. The recovery room is also called PACU. Your nausea and your pain are controlled, and during that time that you're there, when you're ready, you'll be transferred up to your hospital room, and that is on the 4th floor of the med-surg unit. Once you get up to the room, everybody will have oxygen, and that is a nasal cannula that you have in your nose. Everybody will have an IV in their arm. Everybody will be given an incentive spirometer, and you'll see one of these, and you'll be using that about 10 times every hour while you're awake. And the respiratory therapist will show you how to use that. Everybody will have a pulse oximeter on their finger, and that is to measure what your pulse is, and then how well that the oxygen is in your blood. This is what that pulse oximeter looks like. It'll either be taped on or clipped onto your finger. Once you get up to your room, we'll be checking on your vital signs very often. They'll also start you on nutrition, and that'll be like clear liquids, and then you'll move up to sips, and then soups and ice cream, and then we'll just move you up to a general diet. Activity will be as tolerated that first evening. You may even sit up on the side of the bed if that is comfortable for you. But we will help control your pain and your nausea while you're in the hospital. Pain management. It is vital for you to describe your pain, when and how and where it is located. We would like you to rate your pain. 0 is no pain and 10 is the worst. Why we do this is because we want you to use the medication the best it does. Otherwise, if we give you too much medication, then you're not going to be able to get the best therapy and the best out of your surgery. We can use other things like distraction, position change, and just relaxation. Our goal is to not scare you, but prepare you for the pain that you will have after surgery. After hip surgery, everybody will come up with a pillow bolster between your legs, and it'll be done so that you don't cross your legs after you have surgery, because everybody's a little bit sleepy. Ice will be also to your hip incision over your dressing, and that'll be done throughout the whole time that you're here in the hospital, and then once you go home. When you're at home, we do want you to definitely use that ice for any kind of pain. Hip precautions will be taught to you throughout the whole time that you're here in the hospital to prevent that dislocation. This is what that hip bolster looks like. That is only done for the first 18 to 24 hours while you're in the hospital, and then we use pillows. And then once you get home, then you can use pillows between your knees. Length of stay is typically about 2 to 3 nights. You can go home earlier if you're doing well, but the length of stay also depends on how well that you're doing and your insurance coverage. If you plan on staying and going somewhere for rehab, you do need to stay the 3 nights. Postoperative day 1, your blood work will be done very early in the morning, and that is done because the doctor comes in early in the morning and needs to see those results. Your pain control is also going to be done during that time, and we'll kind of switch back and forth on things that work the best. Anticoagulation is either going to be a certain medication, or you could have injections depending on what you and your surgeon have discussed. We'll also be taking care of your nutrition, so if you're just starting on clear liquids, then we'll move you up to a little bit more general diet. Your physical therapist will be coming in that first day, and they'll also start getting you up twice a day already. You are the partner in your care. Postoperative day 2. The person that's going to be taking care of you when you go home should come in just so they can see how to get you in and out of bed, see how the safety is and how the activity, how physical therapy and occupational therapy work with you. This is a great idea to bring in some family that's going to be with you. Day 3, discharge day. We want to prepare for you to be discharged anywhere between 11 and noon that day, but we do realize that if your family can't come in until later on in the day, then we will work with you. The person who's going to be taking care of you should come in and learn about the incision care. Everybody gets a certain dressing that's on when they're in the hospital, and it's good that the family sees how to take that off, and we'll show them how to do that. We'll also talk about how to take your pain medication. It's good for the family to see when and how you act when you're in pain, so then they know to help you out with that when you're at home. If you're using any kind of anticoagulation, whether or not it's warfarin, if you were on that pre-op, or if you're going to be going home on aspirin, then it's a good time to listen to the pharmacist and the nurse talk about that. We'll also assist in getting your pain medication. Do realize that we cannot just call in your pain medications to the pharmacy anymore, so if you need to get a prescription, somebody needs to come here and pick up an actual prescription and take it to your pharmacy. And how to get in touch with your surgeon. It's good to call orthopedics clinics, or you can also use your patient online services, and I'll talk about that in just a little bit. But you are the partner in your care. How to control the swelling of your surgical leg. Physical therapy will talk to you a lot about that, but they'll also tell you that walking and icing is the other thing. Keeping your affected leg elevated also is going to be, it says 20 out of 24 hours, and that means throughout the day. We don't want you just to sit in a chair or the recliner for 20 hours. We want that to be spread out throughout the day, and just make sure that you get up and walk frequently. Elevation, this is a picture of what I was just explaining. Elevating the knees above the hips, toes above the knees, helps decrease the swelling and the pain. This can be done while you're at home. After discharge, the person who's going to be taking care of you should be available 24 hours out of the day. That doesn't necessarily mean right with you, but at least a phone call away. Just to help you at home the first couple weeks, help drive you to your appointments, and help to encourage you in your therapy and get you going in your progress. Bathing, you can shower with that dressing on. It is waterproof, so there is no worries about that, as instructed about the doctor. But do not submerge it at all in any kind of bathtub, pool, hot tub, any kind of lakes or streams. Driving, we do want you to talk with your doctor about when is the best time to do this, but we want you to be off all your narcotic pain medications, be able to sit in the car comfortably, be able to move your foot from gas to brake easily, and practice in a safe area before you do this. Usually we talk about this at your 10 to 14 day post-op appointment, and then we'll tell you when it's safe for you to drive. This is inside the folder that we'll be sending home with you. It's an orthopedic central pain management policy that we have, and it just discussed what I had went into earlier, that all your prescriptions need to be on paper. We can talk to you about phone refills, but I cannot call them into any kind of pharmacy. Our office hours, we are here 8 to 5, but the doctor is here usually about 8 to 4, and that is the best time to talk with them. So if you need any refills, it is best to call or send us a message to the patient online services, and we can get in touch with them. We do only give out limited supplies of prescriptions. We do want you to be in control with your pain, but we do not give out a severe amount of medication. So just know that if you do lose them, we cannot give you another prescription. So if you have any questions about this is good to talk about with the doctor. This is just another way of what I had just mentioned about how you need to pick up your pain medications at the office, the prescription paper. We can also send it through the mail. We can talk to the pharmacy here at our clinic. Do realize that if we do mail it to you, it does take anywhere from 2 to 4 days with our mailing system, so it will take a while if that's the option that you pick. At your follow-up appointment, I had mentioned about 10 to 14 days after your surgery, you'll be meeting with your doctor, and he'll be taking out your staples, give you some instructions about the incision, how to bathe, how to use your crutches or your walker or your cane, kind of discuss those things. This is also a perfect time to talk about your medications. If you need a refill, like you're almost out or you're not quite, you can talk about needing another prescription because you'll be in front of the doctor to get that. Also, we'll talk to you about dental procedures. I had mentioned earlier about how you need to have your dentist appointment, a cleaning or any kind of teeth extraction 1 month before surgery. We don't want you to have any kind of teeth cleaning or mouth, any kind of tooth extraction for 6 months after surgery, unless it is a severe emergency. And that is because we don't want any kind of infection to get into your bloodstream and then go right to your brand new joint. This is also once you get your dental or your protocol, after that is done, we will call in that prescription to your pharmacy of choice, and that will give you some refills so that you'll be able to go to your dentist and you'll take the prescription 1 hour before you go to the doctor. And again, we'll talk about this all at your doctor appointment. This is Patient Online Services. I had mentioned this earlier. This is a great way. It's a secure website that allows the patients to connect via internet. We can talk with your doctor through this. You can talk to any of, not just orthopedic doctors, but your primary doctor and your nurses. We can talk about your lab results. You can see your lab results. You can see your clinical notes. You can talk about your discharge instructions with your doctor on this. You can see a list of your medications. We can also go through prescription refills. You can send me an email, and I can send you and tell you when your prescription is going to be ready here at the desk. We can also look at when your upcoming appointments are, or we can change those. If you have any questions about how to set up this Patient Online Services, I can also help you with that here. And then we can help you get ready for your surgery. If you have any other plans, or any questions, you can go on to our website at the mayoclinichealthsystem.org, and you can find out all the information there, or you can call your orthopedics clinic at any time. Thank you.
Hi, my name is Nicole Marquardt. I'm a physical therapist here at Mayo Clinic Health System, and today we're going to talk about physical therapy following your total hip replacement. We're going to start out by giving you a few pieces of homework before you have your hip replacement. First, we'd like you to open your packet and find your handouts of the exercises that are on the right side of your folder. We'd like you to become familiar with that exercise handout and actually go ahead and start doing those once or twice a day, about 10 repetitions of each. We find that people who have already practiced these exercises have an easier time after their surgery doing them. Your second piece of homework is, if you have a walker, go around your house and practice and be sure that you have plenty of room to get around. We do recommend that you have a 2-wheeled walker and not a 4-wheeled walker. If you do have a walker, we'd like you to bring it to the hospital with you as well. Your therapy will start the day after your surgery, and in physical therapy, we work on the bigger motor tasks, things like your exercises, getting in and out of bed, moving from sit to stand, walking, and doing the stairs. Therapy will continue twice a day until you leave the hospital. We will start your therapy the first morning after the day of surgery, and again, we'll work on getting in and out of bed. The first morning, it just really depends on what you're up for. We'll start with your exercises. We'll get you sitting up. If that goes okay, we'll work on standing. At least try to get you up to a chair, and if you feel up to it, we'll even take a little walk. We'll continue to work on your mobility, going a little bit further each day, along with working on your exercises. You'll continue your exercises at home for about at least 6 months after surgery. We'll work on walking with an appropriate assistive device. We start most patients with a walker, but some patients do prefer to use crutches, especially if they have a lot of stairs in their home. And again, you can bring that to the hospital with you. Especially if you're going to borrow a walker or crutches, we really like you to bring it with you, so that way we can make sure that it's the right size. Walkers and crutches actually both come in 2 different sizes. So if you're 6 feet tall and you're going to borrow your husband's walker, who's 5 feet tall, okay, that was a bad example, switch it around, then the walker might not fit. So that's why it's really important that you bring it with you, so we can be sure that it's in good condition, that it's safe, and that it fits you. And then we'll adjust it for you so it's just the right size for when you get home. We really like it if on the second day you have a family member come with you for the therapy session. And what we can do is the second morning when we're in therapy with you, we can set up a time and know that the family member who's going to be your coach will be there with you in the afternoon, say at around 2 o'clock, and we can come back at 2 o'clock that afternoon. And what they can do then is they can watch how we coach you through your exercises, how we give you tips on how to get in and out of bed, and then that way they're ready to help you do that at home. So after you have your hip, there's going to be 3 rules that you have to follow. These rules are really important to prevent your hip from dislocating. The first rule is no crossing your legs. When you come out of surgery, you'll actually have a big wedge between your legs to remind you not to cross it. But this will be when you're in bed, when you're sitting, you can't cross those legs. The second is no bending your hip past 90 degrees, and that's the line between the side of your body and the big long hip bone. And the third is no turning your toes in, or what you would call pigeon-toed. And that's really important when you are reaching for something across your body. So if you're sitting, you got to reach for things with the hand that it's closest to. Or if you're turning, you can't do big turns. You got to take small turns and keep your nose and toes pointed in the same direction. And we'll practice this when you're walking, when you're getting in and out of bed, and we'll work with you throughout your hospital stay on learning these rules. How much weight you can put on your hip varies after surgery. Some people are partial weight bearing, some people are full weight bearing, and we'll work with you with that after surgery as well, depending on what your surgeon gives us for a restriction. Exercises after discharge will be to walk. We want you to keep walking and gradually increase how far you're walking each day. You'll continue with those exercises that we discussed right at the beginning. The same ones that we'll work with you on in the hospital will be the same ones that you'll continue doing twice a day. You'll add 1 repetition each time you do them and work up to 25 repetitions. And most patients don't have outpatient physical therapy after surgery if they just keep working on those exercises and gradually increasing their mobility. If you have any questions, you can sure direct those to our physical therapy department or your surgeon.
Hello, my name is Marilyn Berg. I'm one of the occupational therapists here at Mayo Clinic Health Systems. Today I'm going to kind of go through the occupational therapy portion of your total joint class and hopefully give you some information to help you better understand what will happen to you during the hospital stay and what to prepare for at home. Occupational therapy is concerned primarily with everyday skills of living, dressing, bathing, grooming, home safety, those types of things, and we certainly want you to be as independent as possible. What we do typically is work on the safest and most independent way for you to do the dressing, bathing, and toileting. We also want you to be participating as independently as possible at home and in the hospital. We want you to have functional strength to do your activities, and we want you to be as mobile as possible. What we will be helping you with is getting some of the equipment that might make you more independent. I did bring some samples today to show you of some of the items that are available. They're not mandatory, but they can certainly help you be more functional at home. One of the first items is the reacher. This can be used for not only picking up things that fall on the floor, but also getting your socks, your pants and your underwear started. By just reaching down, it extends the length of your arm, so it makes it a whole lot easier for you to get your underwear and pants on without assistance. There's also the end of it here that can help you push everything back off. The sock aid is another item that you may or may not find helpful. A lot of people indicate they would love to have it now when they're having trouble reaching down to get their socks on. But there's several styles. With this type, it's a hard plastic. We start by putting the sock directly on the device, like so. You drop it down onto the floor next to your foot. You slide your foot in, and using both hands pulling on the cords equally, you pull your sock on and the device comes away. There are long-handled shoe horns that are available to help you slide your shoes on. They're just like a regular shoe horn. They're just longer and make it easier for you when you can't bend as well. The dressing stick is another option to help you. This hook on this end works similar to the reacher, where you can drape your underwear or your pants on to the end, lower it down to your foot, and then pull them on. The opposite hook helps push everything off, including your socks. Elastic shoelaces are available. Unfortunately, I don't have a sample to show you, but they look like a regular lace. And all the difference is they are elastic. So when you lace them into your shoe, you tie them in a knot so they don't come untied, and then they stretch as your foot goes in or out of the shoe. Just makes it much easier. The long-handled bath sponge is also an option. This is for washing your lower legs and your feet when you're struggling to reach those. Obviously, you can use it for your back or whatever other area that's hard to reach, but the primary reason we show this is for your lower legs and feet. I do have one other item that's not on the list that you see, and this is a leg lifter. This item can be helping you to lift and move your leg when you can't do it yourself. You simply put it over your foot, use your arm power to lift and move your leg, either in and out of the bed, in and out of the car, or wherever you're having trouble lifting your leg. This, however, does not substitute for your physical therapy exercises. A couple of the other things that are listed on the screen are a tub shower bench or a transfer bench. These are items that are helpful if you have trouble stepping over the side of the bathtub, and also the raised toilet seat to make it easier for you to get on and off your toilet. If you have questions on how to get any of these items, the occupational therapist in the hospital can help you to obtain these. Before surgery, we want you to be thinking about safety at home. We want you to pick up any unnecessary rugs, things like by the kitchen or by the bathroom sink that you really don't need, because they're things that you can trip on. They're a different surface than your smooth floor. It's easy to catch your foot and fall. We want you to rearrange your kitchen so items that you use most frequently are in a chest to waist area. That way you're not reaching extensively overhead to one side, down low, where you can fall down. If you were ever thinking about installing any grab bars in your bathroom, now is the time to do that, because they're very helpful with getting on and off a toilet. And we do want you to think about what chairs you're going to be sitting in at home. Chairs with arms are going to be the easiest for you to get in and out of. And also something that's very low and very soft will be very difficult. So think about that before surgery. When you're in the hospital, the occupational therapy staff does come and see you typically day 2 after surgery. We'll see you once a day, and we'll work on bathing, dressing, home safety type skills. And if you need some exercises to strengthen your arms, we do work on those with you as well. We will come in and ask you some questions about your home setup. We want to know what types of obstacles you'll be dealing with. So be prepared to give us a brief summary of your home. We do talk about the home safety instructions. We talk about the equipment I just showed you if you're interested. We do, as said before, instruct you in an upper body exercise program if you need it. And we do actually have you practice getting in and out of a bathtub if that's something that you have to do at home. We really want you to participate in all of the sessions we offer. There's no other way for you to know what you can do and how much help you'll need. And also, this is good information for your caregiver. This is a picture of a practice bathtub with a standard bath chair. This would be something that you may have an opportunity to practice with while you're here. And if you have questions on how to get the bath chairs, please let us know. If you do have any questions or concerns prior to your surgery, please contact your physician or the therapy department, and we'll be happy to help you. Thank you.
Hello, my name is Dana. I am a nurse case manager here at Mayo Clinic Health System in Eau Claire. I would like to give you a brief overview of how the social workers and case managers will get involved in your postoperative care. Social workers and RN case managers work in teams to assist you with insurance and funding issues, counseling and advocacy, transitional planning, and advanced directives for health care. Please make sure that the clinic or hospital has your correct insurance information prior to surgery so that we can pre-authorize your procedure. Pre-authorization for surgery can take up to 30 days to process, so the sooner we have your information, the better. Notification of surgery is not required for those patients who have straight Medicare, as Medicare rules do not require pre-authorization. However, Medicare Advantage plans and private insurance companies do vary in their requirements, and many of them will require not only the hospital to contact them, but the patient as well. This may not be the case for all private insurance companies or all Medicare Advantage plans, but since it's difficult to tell you which companies do have that requirement, please just contact your insurance company and let them know of your surgery plans. If for any reason your insurer were to deny your procedure, the hospital would be notified and we would contact you. Once you are a patient in the hospital, your RN case manager will monitor your days in the hospital and contact your insurance company with updates and answer any questions or concerns that they have. We do realize that being in the hospital is a stressful event for not only the patient but their family as well. Meeting your emotional needs is important to all staff at Mayo Clinic Health System. If you or your family members have any concerns about your care or wish to talk to somebody, please let your staff nurse know and they will locate a social worker or a case manager. Lengths of stay in the hospital are decreasing nationwide. Your insurance company will authorize a number of days based on their criteria as well as your individual needs. In the hospital, your social worker or your case manager will meet with you to discuss your transition plan or what happens after you leave the hospital. As a team, you, your support people, your doctor, and your therapists will determine what is the best transitional plan to meet your individual needs. Home with outpatient services is an option for the person who is generally in very good health and will have somebody to stay with them the majority of time the first few weeks that they are out of the hospital. It is also the patient who has progressed very well during hospitalization with their therapies and is motivated to continue to perform them on a consistent basis while at home. Going home with home care is an option for the person who has a skilled nursing need or a skilled therapy need, such as IV antibiotics or dressing changes. Do keep in mind that the maximum amount of therapy that home care can provide is usually just twice a week. Medicare will pay for home care services if you are homebound and have a skilled nursing or a skilled therapy need. You must meet both of these requirements. Homebound means that you would have a great deal of effort to leave your home. Medicare will not pay for services such as meals, shopping, help with laundry, or housekeeping. Your private insurance companies and Medicare supplement companies do vary greatly in what they cover. So it's a good idea for you to contact your insurance company to see what their requirements are. Skilled nursing facilities are area nursing homes that offer short-term rehabilitation stays along with their long-term care. Generally, these areas are separated by wings or floors within the facility. This is an option for the person who requires more medical care than your family or friends could provide you at home. It might be for the patient who lives alone or is not going to be able to have somebody with them the majority of time those first few weeks post-operatively. It's also for the patient who might need extra help with their therapies or just that motivation to do them. Medicare will cover skilled nursing facilities if you have a nursing need or a therapy need. You also have to have met a 3-night inpatient stay in the hospital. The Medicare Advantage plans and private insurance companies sometimes do not have those requirements. So again, we would check with those insurance companies individually. Transition care units or swing beds are located in smaller rural hospitals, and they provide care by hospital staff and physicians. They're called a swing bed because the hospital will change the usage of the room depending on their needs. The swing bed is an option for a patient who has more of a skilled need than what a skilled nursing facility could provide, but yet they don't need the acute care setting of the larger hospital. These would be your patients with brittle diabetic who needs a lot of blood sugar monitoring, insulin dosage changes, complex dressings, history of heart disease. And then also swing beds can provide a higher level of physical therapy and occupational therapy. Medicare requirements are basically the same as for the skilled nursing facility. So you have to have the need as well as have had 3 nights in the hospital as an inpatient. And again, private insurance companies and Medicare Advantage plans vary. The other thing I would like to speak to you about is advance directives for healthcare. An advance directive is a written document that speaks for you in times when you are unable to speak for yourself. There are 2 types of documents out there. One is the living will, and the other is the healthcare power of attorney. Living wills are also called declaration to physicians. The living will describes the types of life-sustaining measures you would or would not want if you were in a persistent vegetative state or had a terminal a condition that was going to result in death. The living will really only directs your healthcare providers in regard to usage and withdrawal of those life-sustaining measures. It does not give anybody authority to speak for you. The power of attorney, which is also called healthcare power of attorney, is a more broad document. It allows you to appoint somebody as an agent, someone to speak for you and make decisions for you if you are not able to speak for yourself. Your agent will work with your physicians and healthcare providers to make decisions in all types of healthcare needs, not just those life-sustaining measures. Guardianship is a process that needs to be sought if you do not have a healthcare power of attorney in place. This can be a long and expensive process, and it can add stress to your loved ones. This can usually be avoided if you have a healthcare power of attorney completed and on file. While you are in the clinic or the hospital, one of the Mayo Clinic Healthcare System social workers or chaplains can help you complete a healthcare power of attorney, and this is done at no charge. You could also have your personal attorney help you complete the document. They may charge a fee. Before you list agents on your document, it is a very good idea to have a frank conversation with those people to ensure that they are willing to take on this responsibility. It is a good idea to review your document on a periodic basis to ensure that it still represents your wishes. Sometimes people will choose to change their agents or Sometimes the agents listed are unable to be your agent any longer. Perhaps they've passed away, or maybe they can no longer speak for themselves, then they can't speak for you. You should store your document in a safe place, such as a bank safe deposit box, a fire box at home, or a safe at home. You should give a document to your family members, a copy of the document, and you should also ensure that those who are listed as your agent in the document have a copy. Please bring a copy of the document to the clinic or the hospital. We will scan it into your electronic medical record, and it will continue to be on file. If you make any changes to your document, you would need to provide us with a copy of the new document. Thank you.